Good evening, everyone. Thank you for joining us with Dr. Powell for the Prostate Health webinar. Dr. Christopher Powell received his undergraduate degree from Valdosta State University before obtaining his medical degree from the Medical College of Georgia in 2010. His surgical internship, urologic surgery residency, and chief residency were completed at the University of Kansas Medical Center. In August of 2015, Dr. Powell moved with his family to Carrollton and joined West Georgia Urology. A longtime Georgia native, Dr. Powell was happy to return home. He currently performs robotic surgery for West Georgia Urology patients, and a large component of his practice is dedicated to the treatment of urologic cancers. Dr. Powell, I will turn it over to you, and you can begin whenever you're ready.
Okay, thank you very much for that introduction. Caitlin, can you hear me?
Yep, we can hear you good.
Okay, perfect. All right, I'm going to attempt to share my screen here.
Okay.
All right.
Yep,
Can you see it?
Can see it. Looks great.
Perfect. Okay, very good. So this is going to be prostate health kind of 101, and I'm going to go through a few slides, and I'll answer questions at the end. So I'll get started. If you have a question, you can push the purple ask a question button or put them in the chat, I guess. And again, we'll go through those at the end. All right, so a little bit about the prostate. The prostate is located just below the bladder and in front of the rectum. It wraps around the beginning of the urethra. So it sits just below the bladder. It produces fluid that makes up part of the ejaculate. And as men age, the prostate tends to increase in size. Enlarged prostates may cause symptoms not associated with cancer, but BPH symptoms that a lot of folks are more familiar with. Things like weak urinary stream or urgency or frequency, or having to get up at night. We call that nocturia, having to get up multiple times at night, straining to urinate, those types of things. Prostate cancer is one of the most common types of cancer, certainly the most common type of cancer in urology. It often grows slowly and is confined to the prostate, but sometimes can be aggressive and spread quickly. Whenever I talk to someone about trying to identify or diagnose them with prostate cancer, they often ask the question, okay, what do I do if I have it? And that's a really difficult question to answer before we even diagnose a patient. And the reason for that, and I'll go through this more later in the presentation, but the reason for that is prostate cancer really has a wide spectrum of aggressiveness, and it ranges all the way from, okay, you have prostate cancer and we're going to keep an eye on it, but you don't need to be treated right now. You don't need to go through the side effects of treatment, all the way to this is immediately life-threatening and we need to do something right away. So prostate cancer, oftentimes you'll hear a lot of folks say that prostate cancer is not an aggressive cancer. And for the most part, that's true. But that does not mean that you shouldn't be screened for it, because occasionally it is, and aggressive and life-threatening. And we can certainly help with that, particularly if it's detected early. So early detection, like a lot of cancers, is the best chance for successful treatment. You can see in the picture there at the bottom of the slide where the prostate sits right below the bladder, and the urethra goes through it. Okay, some statistics. All men with a prostate, so which is all men, unless it's been surgically removed, are at risk for prostate cancer. 13 out of every 100 will get prostate cancer, and only 2 or 3 out of every 100 will pass away from prostate cancer. The most important or most common risk factor is age. You hear a lot of folks say if you live long enough, everybody will get prostate cancer. It's probably not that extreme, but certainly the older you are, the more likely you are to have prostate cancer. Other risk factors would be being Black or African American, or having a strong family history of prostate cancer. So most patients that have prostate cancer have no symptoms at all. They're diagnosed based on their annual screening, but occasionally folks will have symptoms. Unfortunately, if you're having symptoms and they're associated specifically with prostate cancer, that's a bad sign, because that you may have advanced prostate cancer. Most of the symptoms that I'm going to describe on this slide here are more associated with benign prostate growth and not prostate cancer per se. Those things would include things like difficulty urinating, a weak or interrupted stream, frequent urination, pain or burning when you urinate, blood in the urine or ejaculate. Interestingly, we see a lot of both of those in clinic. Blood in the urine is particularly dangerous. It can be a sign of prostate cancer, bladder cancer, kidney stones, infections, lots of things, none of them great. But blood in the ejaculate is oftentimes benign, oftentimes not a problem at all. It's more scary for guys, which is understandable, but oftentimes if it's worked up, it doesn't turn out to be anything. Again, like I said earlier, that doesn't mean that you can just discount it and not do anything about it. It just means that after a thorough evaluation, most patients are found to be without a significant problem. Pain in the back, hips, or pelvis that don't go away or doesn't go away, that is a particularly concerning sign, especially if you have a high PSA. It could indicate metastatic prostate cancer. Prostate cancer likes to go to the bone, particularly the spine, so that's especially concerning, and painful ejaculation. So when we screen for prostate cancer, the most common and widely utilized test is something called a PSA. I always tell my patients that a PSA is not a great test. It's the most universally available. It can be done at just about any office, any place that runs labs can run a PSA. So that's the reason that I think it is universally adopted. And it's a good starting point for looking for prostate cancer. But a high PSA does not equal prostate cancer. Oftentimes I'll see guys in clinic and they'll be very rightfully concerned that they may have prostate cancer because of their PSA. And I tell them all the time, you need more evaluation. Just a high PSA does not equal cancer. PSA testing is a blood test that measures the level of PSA in the blood. PSA is a product put out by the prostate cancer, by prostate, even a regular benign prostate. And the reason it's associated with prostate cancer is essentially unchecked growth, and so it makes more PSA. Oftentimes when patients come with elevated PSA to our clinic, we'll recommend more specialized testing. There are urine tests and blood tests that are genetic screening tests. They look for specific genetic markers or gene changes that may be better or more specific than PSA testing. More recently, over the last few years, we've been able to do prostate MRIs for certain patients, and that's really, really helpful, because not only does that help us potentially identify our prostate cancer or the risk of prostate cancer, it would help us make a biopsy more accurate, and I'll get into that in a second. So prostate MRI is a great new test available at Tanner. And although nobody wants to have a digital rectal exam, that is an important part of screening for prostate cancer, because several times a year at our office, we'll identify guys who have normal PSAs, but they have an abnormal exam, and on biopsy, they have prostate cancer. So that goes back to the PSA testing being a good starting point, but a normal PSA does not mean that you don't have prostate cancer, and an abnormal PSA does not mean that you do have prostate cancer. So should you get screened? If you're 55 or older, you should be screened at least every other year, according to the new guidelines, although those are, I feel like, constantly in flux, and they've changed a few times in the last decade or so. But certainly if you're 55 or older, you need to be screened. We traditionally do it annually, but technically you could probably do it every other year if you were otherwise low risk. If you're 70 years or older, then the guidelines recommend that you have a conversation with your doctor about whether or not you should and want to be screened. And again, you may not be able to need to be screened as frequently. I think every 2 years, certainly for patients 70 or older, is pretty reasonable if you're low risk, and if you maybe have some other concerning health conditions. That low risk prostate cancer would not necessarily be a big problem for you. If you have a family history of prostate cancer, you may need to start screening earlier. That is the 10-year rule. So if your father was diagnosed with prostate cancer when he was 55, you should start screening when you're 45. So 10 years younger than your family member. Certainly talk to your doctor if you have family history or any signs or symptoms that you're concerned about may increase your risk for prostate cancer. Regarding diagnosis and treatment, in order to diagnose someone with prostate cancer, they have to have a biopsy. That is by far 99% of patients that are diagnosed with prostate cancer are diagnosed with a prostate biopsy. The PSA, the prostate MRI, all those specialized testing that we talked about earlier, they help us get to the biopsy, but you have to have a biopsy of something, traditionally the prostate, in order to diagnose prostate cancer. Traditional prostate biopsies were done utilizing a transrectal ultrasound probe. We would look at the prostate and we would do a template biopsy of the prostate, meaning we don't see cancer. You can't reliably see cancer with a prostate ultrasound. So we would do a pattern of 12 biopsies, 6 from the left and 6 from the right, trying to identify prostate cancer. More recently, over the last couple of years, like we were discussing earlier, the prostate MRI has really, really been helpful for us as far as identifying prostate cancer. For those patients who qualify for a prostate MRI and get one, if there's a concerning spot found on that prostate MRI, they can have something called an MRI fusion biopsy. And in that case, we actually overlay the MRI images with the ultrasound, the real-time ultrasound images, and biopsy the specific concerning spot that was identified on MRI. And numerous times, I don't know the percentage off the top of my head, but numerous times, 20, 30% probably, will identify patients who otherwise have a normal prostate biopsy, but they have a positive biopsy in the area of concern. Let me explain that a little bit better. When we do those MRI fusions, we still do the traditional 12-core biopsy, but we take a few extra biopsies from the area that the MRI noted as being concerning. And a lot of times, patients will have 12 normal biopsies from the traditional template, and then have a positive biopsy of the area of concern. So in our minds, we would otherwise have missed that cancer if not for the newer technology. So that's been really helpful for us and for patients. The 3 most common types of treatment or things that we do with a positive biopsy are active surveillance, radiation, and surgery. Active surveillance, I'm going to go ahead and talk about on this slide. It's basically for patients who have very low risk or low risk prostate cancer who need to be monitored. The guidelines say with a PSA no more frequent than 6 months. In reality, sometimes we'll do every 3 months if it makes patients and ourselves feel better. But you just check a PSA, you continue to follow the PSA. So while it's not a perfect test for screening for prostate cancer, once you have a diagnosis of prostate cancer, you can use that PSA to monitor how aggressive or how much the cancer has progressed. And as long as it remains low risk or very low risk, you may be able to avoid side effects of treatment for years. In fact, the reason that most patients stop active surveillance is not because their cancer progressed, but instead because they just got tired of having to get PSAs every 6 months and the anxiety that can induce, and they just want to have treatment. So active surveillance, though, can be a good option for certain patients. And then there's radiation therapy and robotic surgery. When it comes to radiation therapy, we're talking, at least in Carrollton and at Tanner, we're talking about external beam radiation therapy. That's nothing on the inside of you, no seeds, which are brachytherapy. Everything is done from the outside. You lie on that machine there for just a few minutes, 5 days a week for 6 to 8 weeks, and your prostate cancer is treated. The goal of radiation is to treat just the prostate cancer. They typically treat, this is done by a radiation oncologist, not a urologist like myself, but work closely with radiation oncology. They try to treat the whole prostate, occasionally lymph nodes, depending on the severity of the prostate cancer, but try to treat the whole prostate and nothing around the prostate. That's difficult, and oftentimes in reality, there's a little bit of radiation spillover into the surrounding organs. There's no way to do a good job treating the edge of the prostate without having a little bit of radiation go beyond the edge of the prostate. We do have, it was new when we started doing it, this SpaceOAR technology. We were actually the second site in the state of Georgia to start using the SpaceOAR. Now we've been using it for, I want to say 4 or 5 years. It's a small gel that we inject through a needle placed underneath the scrotum in the perineum. And it actually puts a small gel cushion between the prostate and the rectum so that any kind of radiation spillover beyond the prostate goes into the gel and not into the rectum. So you don't have rectal side effects. And that gel is actually pretty fascinating. It goes in as 2 liquids that combine, turn into the gel immediately, provide that cushion in between the prostate and the rectum, and then over the course of 3 months is dissolved back into a liquid that is absorbed by your body. So it's not permanent. Really neat. Radical prostatectomy, this is a surgery that I do quite a bit of. We do this robotically. More than 95% of these cases are done robotically at Tanner now, probably less than 1 open surgery a year. And that's consistent with the national trend, although the national trend is probably 80% robotic. But we do as many robotic as we can because it's associated with smaller incisions and less blood loss, less pain, and faster recovery. I personally make 6 tiny incisions. They're all about 8 millimeters in size. And to give you some reference, an inch is 25 millimeters. So they're all less than a third of an inch. And we make 6 tiny incisions across the abdomen, remove the prostate, sew the bottom of the bladder and the top of the urethra back together, and insert a catheter that has to stay for about 10 days or so after surgery. Patients typically stay 1 night in the hospital from that surgery, and then don't oftentimes require any other form of treatment unless they have some form of aggressive or advanced prostate cancer. Downtime total is about 6 weeks from the surgery, but a catheter, like I said, for about 10 days and only 1 day in the hospital. So now we're going to go over some just general tips for staying healthy, and these all apply to prostate cancer and prostate health as well. Oftentimes, when I diagnose someone with prostate cancer, they'll ask me, what can they do to help themselves? What can they do to affect their outcomes as far as their prostate cancer? And right now, the best answer I have is just healthy living, healthy a diet, being active, exercising routinely, not smoking. There's a lot of research being done in this arena right now, and all the preliminary data is around general healthy lifestyle that we all know how to do. It's very simple. Exercise routinely, don't smoke, eat heart-healthy diets with lots of fruits and vegetables. Simple but not easy. But that is very important. Certainly getting your regular screening for prostate, colon cancer, blood pressure, cholesterol, those types of things are important. Like we talked about last slide, a healthy diet is critically important. It reduces heart disease and diabetes and obesity. Obesity actually has been linked with advanced prostate cancer. So people who are obese tend to have higher risk prostate cancer when they're diagnosed. So the exact connection between obesity and what causes them to have higher risk prostate cancer has not been identified to my knowledge, but certainly healthy, active lifestyle is associated with better outcomes, and not just of prostate cancer, obviously, of all kinds of health indicators. So obviously surviving prostate cancer can be a stressful period, can be certainly exciting if you have treatment that cures you of prostate cancer. That's obviously very exciting, but follow-up care is important. Regular checkups will absolutely be necessary, no matter if you choose active surveillance or radiation or surgery. Everyone is going to need to be followed closely. In general, we follow folks every 3 months for the first 3 years, every 6 months for the next 2 years, and then annually thereafter. So if you get diagnosed with prostate cancer, we see a lot of each other, and are happy to see people do well. Certainly ask your doctor for a plan of care, which would include diet and physical activity suggestions as mentioned in the previous slides, and regular appointments, even with your primary care. So if you have any questions or concerns, I'll answer those in a second, but certainly we're there to help you. We'd like to see you if you have any questions or concerns or need to be screened or have prostate cancer or have options or questions about imaging for prostate cancer, testing, specialized testing, those types of things. We're happy to help you and see you. And you can call the number on the left there is the Tanner number, the 678, I believe, and the 770 is the West Georgia Urology office. We're happy to see you. And certainly we're actually more involved now on Facebook and social media than we've ever been in the past. And you can reach out to us there as well. Okay, now I'm gonna try to answer questions for you. I guess I'm gonna leave that screen right there if that's okay, Caitlin.
Yeah, you can leave that there. And I have a couple
Okay.
questions to get us started.
Okay.
All right, first question. Does someone diagnosed with prostate cancer continue to see their urologist or do they see a cancer specialist?
Yeah, that's a great question. So a lot of urologists are cancer specialists. And so let's talk about that briefly, about what constitutes a cancer specialist and what types of cancer specialists there are. At Tanner, we have urology, and as Caitlin said earlier, I do most of the cancer for our office, and it makes up well over half, probably 2/3 of my practice. And so I certainly see a lot of prostate cancer and would follow those patients that only need urology. There's radiation oncology that performs the radiation for prostate cancer, and they will often follow patients for a short period of time after radiation. And then I think you're probably talking about, when you say cancer specialist, probably talking about medical oncology, which are the non-surgical cancer docs, the ones that do chemo and certain types of specialized cancer infusions and things like that. Certain patients will need all three of us, urology, radiation oncology, and medical oncology. Oftentimes, if patients have localized prostate cancer, meaning prostate cancer that hasn't spread, they can just see a urologist or have their radiation oncology treatment and then go back to urologist. So most of the time, I think, to try to simply answer your question, urologists are the ones that identify prostate cancer, treat prostate cancer, and follow patients long-term for prostate cancer.
All right, next question. Do patients recover well after treatments or surgery?
Yeah, I think so. I mean, certainly it depends on what your baseline health is. The healthier you are going into any sort of treatment, the better off you are and the better your outcomes are. I have patients who I've performed prostatectomies on who, after their prostatectomy and they're in an appropriate recovery period, have gone back to distance running, have gone back to being active in sports and farming and all kinds of construction, all kinds of very active careers and hobbies. And so I think in general, patients do recover well. The same is true for radiation. Certain patients, we would pick radiation or surgery based on their lifestyle and a life expectancy and things like that. But in general, patients recover really well.
What age range do you see the most having prostate cancer in our area?
Yeah, most patients that we diagnose for prostate cancer are probably in their mid to late 60s. And that's just kind of off the top of my head. I have seen and operated on patients in their 40s. That's pretty uncommon. And certainly we've seen prostate cancer in people in their 70s and 80s. It's, as you get older, you have to start weighing the risk of prostate cancer identification and treatment versus quality of life. And what I mean by that is if you're identified with low risk prostate cancer and you're in your 80s and you have significant heart conditions and lung conditions and things like that, you may not want to know if you have prostate cancer. Prostate cancer is very unlikely to affect your length of life or quality of life or things like that. So there probably is more prostate cancer in patients in their late 70s and 80s, but at a certain point, they have more pressing concerns. And so because of that, we probably identify and treat more patients who are probably in the late 60s.
All right. And our next question is, what is the purpose of the prostate?
So the prostate basically helps liquefy and add some fluid to the ejaculate, is what its actual purpose is. For guys, it's not necessarily designed for this, but a lot of guys, we come to rely on it for our urinary continence, meaning that it helps us not leak when we laugh, cough, and sneeze, just because of its size and shape and where it's positioned. That's what most of us use it for as we get older. That's one of the reasons that when patients have their prostate removed, stress incontinence, which is the leaking when you laugh, cough, and sneeze, is an issue until guys learn to use their other pelvic floor muscles. But in general, it's used to help liquefy the ejaculate.
All right. And we have a question. He's asking for you to speak more on the hip type pain. I don't know if this is
the hip pain.
Yes.
Yeah. Okay. The concern with that is that prostate cancer likes to go to the bone. It likes to go to hip and spine and things like that. You know, if you had a hip pain, and I can't necessarily say exactly what type of hip pain, but if you just had what you would consider to be bony pain, you should probably just have a PSA. If you haven't got one in a while, it may be even more important for you to get one. And if it was especially high, then that would be concerning, that the hip pain could be from prostate cancer. That's somewhat rare, but probably a handful of times we'll see that. That's typically guys who have not gotten their annual screening with their primary care or their urologist, and you know, they show up never having been screened, and they're in their late 60s and they have new back pain, and you check a PSA and it's a normal PSA, I should say, is less than 4, but you might check a PSA and it's 500 or 600. You know, that's when we start getting concerned that, okay, that bony pain might be from metastatic prostate cancer. But I would say in general, if you're doing your regular PSA screenings, you're probably okay.
And what is the most common symptom you see of prostate cancer before it's actually diagnosed?
Yeah, well, I'll answer this 2 different ways, I guess. The most common symptom is just no symptoms at all. And I would say that that's 90% plus of prostate cancer diagnoses. If we do see a symptom, more commonly, it's probably something vague like erectile dysfunction. And that's a kind of a hard thing to pin on prostate cancer, because a lot of guys in their mid and late 60s have erectile dysfunction and they don't have prostate cancer. But I would say if you have kind of a new onset erectile dysfunction, that would be another flag that you should probably get your PSA checked.
All right, we don't have any more questions rolling in. Does anyone else have any more questions for Dr. Powell? If you do, you can type them in the chat box. I'll give just a couple minutes for anybody. Next question, when is the next screening at Tanner?
That is a good question.
I actually have an answer for that.
Oh, perfect. Okay, good.
We are scheduling screenings for November. We don't have any dates secured, but it will be in November.
Okay, I do have a, let me see. Okay, I do have a kind of a random community plug for this as well. June the 11th, so right around the corner, Dr. Rouse, one of the local cardiologists, is doing a King of Hearts event where he's going to do cardiac, so heart education and information that's going to include kind of cardiac screening, colon cancer screening, and prostate cancer education. So June the 11th, there's an event with Dr. Rouse.
That's great. If you can send me that information tomorrow, Dr. Powell, I can email that out to the participants tonight.
Yeah, I'll definitely send it to you. If you're Googling, it's King of Hearts. Like I Googled the other day, King of Hearts, Carrollton, Georgia, and I was able to find it, but I'll definitely send that to you.
Perfect. All right, we got questions coming in.
Okay.
Does a vasectomy help cut down the risk of cancer?
Oh, that's a great question. It does not. It does not cut down the risk of cancer or increase the risk of cancer, which in the 80s, 1980s, they thought that there was a study that came out that said maybe having a vasectomy increased your risk of prostate cancer. That was later proven to be untrue. I think it was just, you can oftentimes make statistics kind of do what you want them to do, and association doesn't necessarily mean causation. And what I mean by that is a lot of guys get vasectomies and a lot of guys get prostate cancer. So those are, if you were to do a big statistical analysis, you may say that those are linked. They're not, and they were later proven to not be associated. But there was that thought in the 80s.
Another question is, what is a typical good PSA number?
Yep. So traditionally, less than 4 is considered a good PSA. That's just kind of a rough rule of thumb, though, because like I said, I have seen guys with prostate cancer and they have a PSA of 3. I've seen guys without prostate cancer and they've had all the specialized testing I've talked about, multiple negative biopsies, prostate MRI, all that kind of stuff, when we haven't identified prostate cancer and they have a PSA of like 17, 18. So in general, if you're looking at a lab sheet, you're going to see PSA less than 4 is considered normal. But that is just a starting point.
All right, does anyone else have any more questions? Okay, Dr. Powell, how does not having a prostate affect the quality of life?
Yeah, so if you have a prostatectomy, it certainly is a quality of life hit initially. Everybody that has a prostatectomy has problems with stress incontinence, like we talked about earlier. So that's, at first, it's problems with incontinence, period, almost no control of the urine. That quickly gets better, and patients have stress incontinence, meaning incontinence when they when they laugh, cough, sneeze, those types of things. Using exercises and time away, so time to heal from surgery, that tends to get significantly better. But certainly stress incontinence is an issue with quality of life after prostatectomy. The other side effect of having your prostate removed is everybody has a decrease in their ability to have an erection. That doesn't mean that you never have erections again. It just means wherever you start, it's not going to be as good as it was prior to your prostate being removed. And those are the 2 side effects that everybody has, no matter who or where you have who removes your prostate or where your prostate's removed, or whether it's removed open or robotic or any of the modalities to remove a prostate. Everybody has leaking at first, and everybody has problems with erections. So those are the 2 things I think that affect your quality of life. But as we spoke about earlier, long term, those things tend to get better, and patients, go on to do whatever they want to do. A lot of that depends on how healthy you are before you get treated. If you don't have great erections before you have a prostatectomy, you're going to have even worse afterwards. And so that goes back to those last slides, just being as healthy as you can be going into some sort of treatment like that. But otherwise, there aren't really any other major quality of life adjustments. Guys don't have an ejaculate after having their prostate removed. That's more of a cosmetic type thing, but that's it. So it can be good. It can be good.
All right, that may be our final question. Thank you, Dr. Powell, for such a good presentation.
Sure thing.
And
Thanks for
thank
having
you.
me.
Yes, absolutely. Thank you, everyone, for joining us. You all can continue to check out tanner.org for other classes and events that we will host. And if anyone doesn't have any more questions, we will close out. All right. Well, I guess that's it.
Okay, thanks so much.
Thank you. Good night, everyone.